I am Dr. Sham, MBBS MD Physiology. Today we will be learning about anticoagulants and the Plasmin system. Initially, we will see mechanism of coagulation which is normally present in our body to arrest bleeding when there is a vascular injury. So, the coagulation can happen in two pathways, that is via intrinsic pathway of coagulation and the extrinsic pathway of coagulation. The intrinsic pathway of coagulation which is being shown, we can see that when there is a blood trauma or injury to the blood vessel which is leading on to the exposure of subendothelial collagen, it will lead on to the activation of factor 12. This factor 12 will lead on to will form activated factor 12, and this activated factor 12 along with high molecular weight kininogen and prekallikrein will activate factor 11 to activated factor 11, and this will activate factor 9, and along with factor 8 it will further activate the factor 10 into activated factor 10. The activated factor 10 along with thrombin, activated factor 5 and platelet phospholipid in presence of calcium will lead on to the conversion of prothrombin to thrombin. So, the entire thing, that is activated factor 10 along with calcium, factor 5 and platelet phospholipid, this entire complex is the prothrombin activator which will activate prothrombin to thrombin, and the thrombin will further lead on to activation of fibrinogen to form fibrin. And there is another mechanism of coagulation, that is the extrinsic mechanism of coagulation, which is not shown in this picture. In extrinsic pathway of coagulation, there will be tissue injury and it will lead on to the release of tissue factor or tissue thromboplastin, and this tissue thromboplastin will lead on to the activation of factor 7, and this activated factor 7 will further lead on to the activation of factor 10, and the active factor 10 further onwards it is the common pathway, that is it will stimulate the prothrombin to convert into thrombin, and further fibrinogen will be converted into fibrin. So, this is the pathway of coagulation that we should be clear about. Now, in the clinics as well as in laboratories, the blood is being collected for various studies, and in those studies we need to collect the blood and we should prevent the clotting of the blood. For that purpose, we have to use certain anticoagulants. So, it is not that anticoagulants is used only in the clinics, but anticoagulants are naturally present in the body as well. We will see various anticoagulants which are present within the body as well as various anticoagulants that are used as drugs that are used in the laboratory procedures for the collection of blood. Coming into the anticoagulant agents in vivo, that is present within the body, which is of physiological importance, that is to prevent the clotting of blood within the body, that is to maintain the fluidity of blood when it is present in the blood vessel. So, the anticoagulant agents present in the body are the tissue factor pathway inhibitor, the thrombin thrombomodulin complex, the antithrombin 3 heparin complex, and finally the tissue type plasminogen activator. We will be understanding about all of these systems in detail in the coming slides. So, this is the most important anticoagulants in vivo that is present within the blood vessel to prevent the coagulation of blood within the blood vessel. Now, coming to the anticoagulants which are used in laboratory, that is which are in vitro, that is used when the blood is outside the body, it is called in vitro. They are heparin, oxalates, citrates and EDTA. We will be understanding each of them and the mechanism of action in the further slides. So, these are the substances or anticoagulants that are used in the laboratory procedure to prevent the collected blood from getting clotted, and they are in vitro anticoagulants. And finally, the last class of anticoagulants is the therapeutic anticoagulants, which are given into the patient, that is either consumed orally or given as IV or subcutaneously to the patient, so as to prevent the onset of various thromboembolic disorders as well as for the treatment of various thromboembolic disorders. And the therapeutically used anticoagulants are heparin, dicumarol, which is a vitamin K antagonist, and we will understand in detail that is how it is acting. So, vitamin K is important for the production of various clotting factors, which is 2, 7, 9 and 10, they are the clotting factors, and protein C and protein S are the anticoagulants or anti-clotting agents which are present normally within the blood. So, dicumarol, which is a vitamin K antagonist, will prevent the formation of these clotting factors. And finally, warfarin, which is also an example of vitamin K antagonist. As the continuation, we will see further examples of therapeutic agents, that is therapeutic anticoagulants. They are tissue type plasminogen activator and streptokinase, which is used in acute ischemia of the ventricles or heart, that is in myocardial infarction, as well as it is therapeutically used in stroke patients. And we have the aspirin, which is a drug which is used to prevent the activity of platelets, that also can be used as a prophylaxis to prevent the formation of clot in patients having high risk of cardiac diseases. Now, coming to the mechanism of action of various anticoagulants which are present in vivo, that is, which are present within the body or within the blood vessel, which prevents the clotting of blood while it is present inside the blood vessel. We all know that when the blood is present within the blood vessel, it is not good for the blood to clot, because we need a constant flow of blood. If some area is getting clotted, then certain area will not be receiving blood and can undergo ischemia, as well as the clot which is formed in the blood vessel can dislodge into some other areas as embolus, and that can also lead on to fatal complications like pulmonary embolism. So, there is a need that the blood should be preserved or blood should be kept as a fluid form while it is present in the blood vessels. So, the factors which maintain that fluidity of blood are the endothelial factors. There are certain endothelial factors we will learn, and other than that, the factors are tissue factor pathway inhibitor. The first one, tissue factor pathway inhibitor or TFPI, it is the abbreviation. As the name indicates, this prevents the clotting of blood via the extrinsic pathway, because tissue factor is the most important or the initiating factor in case of extrinsic pathway, that is thromboplastin, which is released as a result of tissue injury, will cause stimulation of the factor 7. That is why this pathway inhibitor is called as tissue factor pathway inhibitor, and it inhibits the extrinsic pathway of coagulation. Thrombin thromboplastin complex, and the third one is antithrombin 3 and heparin complex. And all of them will limit the clot formation within the blood vessels. Now, coming into the first one, that is the tissue factor pathway inhibitor. The tissue factor pathway inhibitor, this is an inhibitor protein which is secreted by the endothelial cells. One of the most important property of the endothelial cells is to secrete various anticoagulant as well as various antiplatelet substances which will prevent the formation of clot within the blood vessel. So, this is another example of such a factor, that is the tissue factor pathway inhibitor, which is secreted by the endothelial cells. These endothelial cells secrete this pathway inhibitor, and this inhibitor will bind to the factor 7A and the factor thromboplastin, that is the tissue factor or tissue thromboplastin. We have already seen in the extrinsic pathway that the tissue factor will activate the factor 7A and further it will activate the factor 10A. So, the function of TFPI or tissue factor pathway inhibitor is it inhibits the tissue factor 7A complex, that is, it inhibits the first step in extrinsic pathway of coagulation, and thereby it further inhibits the generation of 10A, because we have already seen that the last step of this extrinsic pathway is the activation of 10A and further on the activation of fibrinogen. So, as it is inhibiting tissue factor and 7 factor, further on it will inhibit the factor 10 also. And finally, this is controlling the initial phase of coagulation via the extrinsic pathway, thereby adequate amount of thrombin will not be generated, because thrombin is generated and that thrombin is needed for further positive feedback or further increasing the rate of formation of the further steps or further clotting factors for activation of the further clotting factors. So, as it is preventing the formation of thrombin, it will control the clotting formation in the initial stage itself. So, this is about the tissue factor pathway inhibitor. The next mechanism of anticoagulation present in vivo is the thrombin thrombomodulin complex. We have already seen that the conversion of prothrombin to thrombin is the final pathway in both intrinsic as well as extrinsic pathway of coagulation. And this thrombin which is generated will further activate the production of various other or further enhances the activation of various clotting factors, and further it can increase the coagulation process within the site of injury. So, how to control the formation of the thrombin at the site of injury? So, for that purpose, thrombin itself will be binding upon another factor which is called as thrombomodulin. So, this thrombomodulin is a protein which is secreted by the endothelial cells, as you can see here. So, endothelial cells will secrete thrombomodulin, and the thrombomodulin will bind to the thrombin, and the thrombin which is generated locally at the site of injury should not spread to the further surrounding site, so that the unnecessary thrombosis of the surrounding sites can be prevented. So, for preventing the excessive coagulation, the thrombin which is formed as a result of coagulation will bind to the thrombomodulin, and this leads on to the activation of protein C. Protein C along with protein S is a part of anti-clotting mechanism present in the body, and this protein C will inactivate the inhibitor of the plasminogen that we will see later. That is, plasminogen is an anticoagulant factor or a fibrinolytic factor. So, what this protein C do is, you can see activated protein C is inhibiting the factor 7 as well as the factor 5. So, when this factor 7 and factor 5 is inhibited, it will inhibit the formation of further thrombin, and thereby it will prevent the formation of clot. So, this is the second mechanism which is present within the blood vessel to avoid unnecessary clotting or clotting of areas which are surrounding the site of injury. So, the excessive thrombin will bind to the thrombomodulin which is secreted by the endothelial cells, and this will lead on to activation of protein C, and protein C will inhibit factor 7A and factor 5A. And the third mechanism which is present within the body or within the blood vessel is the antithrombin 3 molecule. This antithrombin 3 molecule alone does not have much anticoagulant action. It has an inhibitory effect on factor 12 and 11, but the anticoagulant property is not very high. But heparin, when it binds to antithrombin 3, it enhances the ability of the antithrombin 3 to inhibit coagulation around 1000 times. So, alone heparin as well as antithrombin 3 is not having much anticoagulant action, but when it is bound to each other, it will have a higher ability to inhibit coagulation. So, heparin after binding to antithrombin 3 will inhibit or inactivate these factors. They are thrombin, factor 11, 12, 10 as well as 9. So, these are the 5 factors which are inhibited by the heparin antithrombin 3 complex when they are bound to each other. So, it prevents, as I told, it will prevent the spread of coagulation to the nearby sites, because the need of coagulation is only at the site of injury. It should not spread to the surrounding site or nearby blood vessel, because if it is spreading to nearby blood vessel, it can lead on to thrombosis of the entire blood vessel and can lead on to ischemia of the tissue supplied by that blood vessel. So, to prevent that, these mechanisms will act. So, they are the antithrombin 3 mechanism, thrombin thrombomodulin complex, and tissue factor pathway inhibitor. All of them are secreted by the endothelial cells, as we have already seen. We will see the other functions of endothelial cells in preventing the coagulation. So, in this picture, you can see the anticoagulant or anti-clotting roles of the endothelial cells. So, the first action is to provide an intact barrier. We know that the capillaries or the blood vessels are lined up by endothelial cells in the inside, so that it is providing a smooth covering. There is no breach in the endothelium. So, the smooth covering of the blood vessel will prevent the exposure of collagen, and if the collagen is exposed, then what will happen? It will cause activation of the factor 12, as we have already seen in the intrinsic pathway of coagulation. The primary role of endothelial cell is to maintain a smooth surface in the interior of the blood vessel. The next function is to release prostacyclin as well as nitric oxide. We know prostacyclin and nitric oxide are vasodilators, and they are inhibitors of platelet activity. Thereby, platelet aggregation and activation is prevented and primary hemostasis is prevented. The next function of endothelial cells is to secrete tissue factor pathway inhibitor. We have already seen this function in the first slide, that is, it will release tissue factor pathway inhibitor, and this will inhibit factor 7 and factor 5. And the next function is to bind thrombin via thrombomodulin. This also we have seen that the endothelial cells will be secreting thrombomodulin, and this thrombomodulin will bind to thrombin and inhibits further production of clotting factors. And the next one is to display heparin molecules, and we have seen that heparin is also an anticoagulant which is having an inhibitory role on 11, 12, 9 and 10 clotting factors. And finally, endothelial cells are also responsible for secreting the tissue plasminogen activator. This tissue plasminogen activator is an important substance or an important protein that will cause activation of plasminogen. We will see in the further slides that plasminogen is a factor that will help in lysis of the clot or lysis of the coagulum that has already been formed. Now we will see about the anticoagulants which are used in vitro. We have already seen about the anticoagulants which are present in vivo. Now we will be seeing the anticoagulants which are used in vitro. In vitro, it can be used for two purposes. One is for laboratory purposes for collection of blood, and the second is for therapeutic purpose to prevent as well as to treat various thromboembolic disorders. First, we will see the anticoagulants which are used in the laboratory, that is to prevent the coagulation or clotting of the collected blood for laboratory analysis. So, the various anticoagulant substances which are used are ethylene diamine tetraacetic acid, or it is commonly known as EDTA. The mechanism of action of ethylene diamine tetraacetic acid is it binds to calcium and it forms insoluble complex with ionic calcium, so that the calcium is removed from the blood. If you remember about the first picture, that is the pathway of coagulation, we have seen that calcium is one of the most important substance which is acting as a cofactor in each step of coagulation. So, when calcium is removed from blood, it will automatically prevent the coagulation pathway to happen and it will prevent clot formation. So, this is the mechanism of action of EDTA. Now, coming into the second substance or second anticoagulant which are used in vitro, that is in laboratory, it is sodium citrate. So, sodium citrate is also having the same mechanism of action. It will inhibit calcium ions by binding to calcium ions and forming insoluble complex. And double oxalate is another anticoagulant which is a mixture of ammonium oxalate and potassium oxalate. This is used in various hematological investigations. The mechanism of action remains the same, that is, the oxalate salt will cause complex formation with calcium and thereby prevents the free calcium levels in the blood, and thereby it will prevent clotting to occur. And the next one is sodium fluoride. The sodium fluoride is having an inhibitory effect on the glycolytic enzymes. So, sodium fluoride is the most common anticoagulant which is used in estimation of glucose analysis in blood. And coming to the next one, that is heparin. We have already seen the mechanism of action of heparin, that it binds with antithrombin 3, but that mechanism is happening in vivo because antithrombin 3 is present within the endothelial cells. The mechanism of action of heparin in the blood which is collected is not similar, but it inhibits factor 12 and 11, but not in combination with antithrombin 3. Now, coming on to the next type of anticoagulants which are used in vitro or which are used outside the body, which are not in vivo basically, which are used for therapeutical purpose. They are two types. They are either oral anticoagulants or they can be intravenous or subcutaneous anticoagulants. Initially, we will see the oral anticoagulants. So, first of all, we have to understand what are the vitamin K dependent clotting factors. So, vitamin K is a most important vitamin which is needed for formation of clotting factors. The clotting factors which are dependent on vitamin K are 2, 7, 9 and 10. So, this is important for gamma carboxylation of glutamic acid residues. This vitamin K in its active form is required for the gamma carboxylation of the glutamic acid residues in these clotting factors. So, why gamma carboxylation of glutamic acid residues is needed? Because it is needed for the binding of calcium, and calcium is one of the most important cofactor required for clotting process. So, vitamin K dependent clotting factors are 2, 7, 9 and 10. So, what will this oral anticoagulants do? So, oral anticoagulants, the most common or most widely used oral anticoagulants are vitamin K antagonist. That is, it will inhibit the formation of active vitamin K, or vitamin K epoxide reductase it will inhibit. We will see what will happen when vitamin K is not present in the active form. So, the example of vitamin K antagonist is dicumarol as well as warfarin. Both of them will inhibit the vitamin K epoxide reductase enzyme. You can see this is the enzyme which is inhibited by these two drugs. So, when vitamin K epoxide reductase enzyme is inhibited, it will prevent the formation of active form of vitamin K, which is important for the gamma carboxylation of 2, 7, 9 and 10 clotting factors. So, as a result, 2, 7, 9 and 10 clotting factors are not formed or not processed properly. As a result, the clotting will be withheld. The next group of drugs that can be used orally are glycosaminoglycans. The important example, as we have already discussed, is heparin. And the next group of drug is inhibitors of activated factor 10. We have already seen that factor 10 is the common step which is present in both intrinsic as well as extrinsic pathway of coagulation, because factor 10, once it get activated, will lead on to the activation of prothrombin to thrombin, and further it will activate the formation of fibrinogen to fibrin. So, the most important step or the common step is activation of factor 10. So, there are various drugs that will inhibit the activation of factor 10, that also can be used as anticoagulants orally. Now, coming to the next group, that is intravenous or subcutaneous anticoagulants, and the two most widely used anticoagulants which are intravenous or subcutaneous are heparin as well as hirudin. The mechanism of action of heparin we have already discussed, that is, it binds with antithrombin 3 and it inhibits the formation of factors 12, 11, 10 and 9. The function of hirudin, it binds to thrombin and it acts as an inhibitor to thrombin. Thereby, thrombin is not able to enhance the production of further clotting factors. So, now we will see various investigations that are done to assess hemostasis. We know that there are two mechanisms of hemostasis. One is temporary hemostasis and next one is definitive hemostasis. Temporary hemostasis is the process of vasoconstriction and platelet plug formation at the site of vascular injury, which is just a temporary process to arrest the process of bleeding. And definitive hemostasis is the formation of blood clot at the site of vascular injury, thereby permanently sealing the site of injury. So, based on these two functions or based on these two processes, the investigations that are done to assess the temporary hemostasis is different from the test to assess the permanent hemostasis. So, the tests which are done to assess the temporary hemostasis are bleeding time, capillary fragility, platelet aggregation test and platelet adhesiveness test, because these are the activities which are involved in the temporary hemostasis or platelet plug formation. And the tests which are done in definitive hemostasis are clotting time, prothrombin time and activated partial thromboplastin time. We will see in detail about the most common tests which are done in order to assess the process of hemostasis. So, initially going to the test, that is bleeding time. So, bleeding time is a test, as we have already seen, which assess the temporary pathway of hemostasis, that is platelet plug formation and vasoconstriction. The normal bleeding time is around 1 to 5 minutes when it is done using Duke's method, that is by pricking the earlobe and collecting or soaking the filter paper every 30 seconds and finding out how much duration the bleeding was there. So, based on that Duke's method, the normal bleeding time is around 1 to 5 minutes. And this is to assess the platelet structure, platelet function, platelet number, as well as the vascular function. That is, the ability of the blood vessel to constrict when an injury is occurring. So, this bleeding time assess the temporary hemostasis mechanisms. Next is the clotting time, which is the next most important assessment or test for hemostasis. As we have discussed, clotting time will assess the permanent hemostasis, and clotting time is normally done with the help of a capillary glass tube. In the capillary glass tube, we will collect blood and keep it within your hand to maintain the body temperature, and you will slowly break from one end where blood is there, and you will stop at the point when you see a proper fibrin thread. So, the time between the onset of bleeding and the time of obtaining the fibrin clot, the time interval between these two events is taken as clotting time. So, the normal clotting time using capillary glass tube methods is around 2 to 8 minutes, and clotting time is prolonged in diseases when there is deficiency of these clotting factors. There are various disorders where the clotting factors are deficient or maybe dysfunctional. We will be discussing in later classes. This clotting time is prolonged in various diseases where clotting factor is deficient or dysfunctional. If the clotting time is coming for more than 10 minutes, that is, it is going above or beyond the normal range, then what we have to do is we have to individually assess each coagulation factors or each clotting factors to find out that which particular clotting factor is deficient. The next test to assess the coagulation is prothrombin time. So, in prothrombin time, what is done is the blood is collected from the patient and it is decalcified using some anticoagulants which is used in vitro. Then the blood is centrifuged and the plasma is taken. And to this plasma, we will add excessive calcium along with tissue thromboplastin. And this will lead on to activation of the extrinsic pathway, and it will lead on to formation of the clot within the plasma. This occurs within 12 to 16 seconds, and this is due to the activation of stage 2 of coagulation. It assesses the stage 2 or integrity of the stage 2 of coagulation. As we know, the tissue thromboplastin or the tissue factor is involved in the extrinsic pathway of coagulation. This prothrombin time assesses the extrinsic pathway of coagulation, and it will be prolonged in case of deficiency of factors which are involved in the extrinsic pathway. So, the prothrombin time is prolonged in the deficiency of factors 2, 5, 7 and 10 which are specific to the extrinsic pathway. Now, coming to the international normalized ratio, that is INR. Before analyzing the prothrombin time, we have to convert the prothrombin time, or we have to obtain the international normalized ratio for that particular test, because the type of tissue reagent or the tissue factor used in different laboratories will be different. So, the prothrombin time will vary from the lab to lab, or even it can vary from time to time in the same lab, because the potency of the tissue factor which is used for this test might change at different times. So, the prothrombin time will vary depending upon that. As a result, what happens is, while we analyze or while we make any conclusion regarding the prothrombin time, if we are taking two different tissue factor at two different times, we might end up in trouble. We might be confused about the actual prothrombin time. So, to avoid such confusions, we will take or we will obtain a value called as international normalized ratio, which is obtained from the prothrombin time of the patient and the prothrombin time of a normal control. And how to obtain this international normalized ratio? It is by this formula, that is prothrombin time of the subject divided by the prothrombin time of the normal subject or the control raised to the power of international sensitivity index. Now, what is this international sensitivity index? International sensitivity index is the indication of the power or the strength of the tissue factor which is being used. So, whenever in any laboratory, if some suppliers are giving the tissue factor, or some manufacturers are giving the tissue factor, then in that tissue factor there will be a label of international sensitivity index, which will give you an idea about the potency or the strength of that particular batch of this tissue factor. The obtained INR can be compared between patients or between time to time to conclude about the bleeding tendency or about the prothrombin time of the subject. Instead of using prothrombin time directly, this is a better, or this is a normalized value which will not vary in different labs, or it will not vary from time to time. The normal range of INR, or international normalized ratio, is around 0.9 to 1.3, and when the INR is increased beyond this, it indicates that there is a tendency of bleeding in the patient, and when the INR is less than 0.9, then it indicates that the patient is having a higher risk of thrombosis in the body. When the patient is on anticoagulants, example warfarin, we have to find out this INR and we have to keep it under the control. Otherwise, the patient can go for excessive risk of bleeding, as we are continuously giving anticoagulants. As we discussed, higher INR will indicate higher risk of bleeding. Now coming to the next part, that is fibrinolysis. So, as we have discussed, in response to a vascular injury, there will be production of clot at the site of vascular injury. This clot should be sealing only the injured part and it should not spread to the surrounding part. So, how it is prevented from spreading to the surrounding part, we have already seen. That is with the help of various anticoagulant factors which are present in vivo. Let us recall, they are antithrombin 3 heparin complex, thrombin thrombomodulin complex, and tissue factor pathway inhibitor. Along with these three, there is another pathway which will prevent the extension or spread of this thrombosis to the further surrounding areas, and that pathway is called as plasminogen pathway, that is fibrinolytic pathway. What it does is, it will lyse or it will break down the excessive clot which is formed at the site of injury and which is formed at the peripheral or nearby the sites of injury. So, we will see the components of the fibrinolytic system, which is also called as Plasmin system, and we will see the mechanism of it. In this picture, we can see the prothrombin is getting converted to thrombin via two pathways, that is intrinsic as well as extrinsic pathway, as well as it is getting stimulated by the factor 12, and fibrin is formed from the fibrinogen, which is the last step of coagulation. Now, the process of fibrinolysis is to break down this fibrin. So, what happens is, in fibrinolytic pathway, there will be plasminogen molecule, which is a protein, which is an inactive protein. It will be converted to plasmin with the help of various substances. If you remember, we have seen in the discussion of anticoagulants in vivo that the thrombomodulin thrombin complex is activating the proteins protein C. Along with the protein C and protein S, there will be activation of plasminogen. So, this plasminogen is coming here. The plasminogen is getting activated into plasmin, and this plasmin is the active protein which will break down this fibrin into fibrin degradation products or FDPs. So, this is the fibrinolysis in brief. We will see the steps of fibrinolysis, components of fibrinolysis, and the mechanism of action in the further slide. So, this is the complete picture of the fibrinolytic system. So, as we discussed, along with the activation of clotting, as the thrombin is getting activated and fibrin is getting formed, simultaneously this pathway also is getting activated, that is fibrinolytic pathway is also getting activated simultaneously. So, you can see the endothelial cells which is having thrombomodulin in it is binding the thrombin, and the thrombin will activate protein C to activated protein C. The activated protein C along with protein S will inactivate factor 8, also it will inactivate factor 5. These are the two functions of protein C. Now, another most important function of protein C is this central arrow, that is, it inactivates the inhibitor of tissue plasminogen activator. That is, indirectly it will activate plasminogen. It will inhibit the inhibitor. So, this is the disinhibition. So, it activates the plasminogen activator. Thereby, plasminogen is converted to plasmin. So, plasminogen is the inactive form of this fibrinolytic mechanism that is activated and converted to plasmin, and plasmin can break the fibrin thread as well as it can destroy fibrinogen also. Thereby, the plasmin is responsible for breaking out fibrin and release of fibrin degradation products. So, activated protein C is the initial mechanism or initial step in the activation of this fibrinolytic pathway for your understanding. So, we have normally within our body, that is within the human body, there are two kinds of plasminogen activators. They are tissue plasminogen activators and urokinases. So, tissue plasminogen activators is secreted by the endothelial cells. You can see here the TPA and UPA. This TPA is tissue plasminogen activator and UPA is urokinase type of plasminogen activators. So, what happens, we have already discussed, this activators will be activated. That is, when protein C is activated, that can enhance the activation of tissue plasminogen activator and urokinase activator. As a result, plasminogen will be converted to plasmin and plasmin will break down fibrin thread as well as fibrinogen. Thereby, it will cause the lysis of clot. So, this is the forms which are present in humans. They are not having much strength, actually they are less potent compared to the Desmodus rotundus salivary plasminogen activator. This is nothing but the vampire bat. So, I just want to tell that the strength of plasminogen activator present in human body is not that much, means the activity of tissue plasminogen activator is not much as compared to the activity of the same present in vampire bats. In today's discussion, we have discussed about the pathway of coagulation, including the intrinsic mechanisms of clotting as well as the extrinsic pathway of clotting. We have listed the important anticoagulants that are present in vivo as well as the anticoagulants which are used in vitro for the laboratory usage as well as for therapeutic purposes. We have studied the mechanism of action of all the anticoagulant substances. Later on, we have studied about the tests which are used to assess the thrombosis or to assess the hemostasis mechanism. We divided into primary hemostasis and secondary hemostasis. We studied about bleeding time, clotting time, prothrombin time, activated partial thromboplastin time as well as international normalized ratio. And at the end, we studied about the fibrinolytic mechanism which include protein C, protein S, plasminogen, tissue plasminogen activators and urokinase type of plasminogen activators, and we have studied how it is preventing the excessive formation clot and how it is lysing the clot which is formed in unwanted or unnecessary areas. Thank you.